Hello, everyone. Today we are going to be talking about neurodevelopmental disorders. And these are typically disorders that occur in childhood. So if you're a school counselor, go ahead and pay attention because this could be really helpful for you. Or if you're working with other children, this could be good for you as well. I'm going to take that sweater down. Okay. My apologies. All right. You'll get used to my mess in these videos because I do this at home. So you'll get to see lots of different hanging sweaters, possibly a cat. There's all kinds of exciting things here. So I'm excited to have you here. All right. Okay. So we've got a lot going on in neurodevelopmental disorders. So hold on to your hats. Okay, so what are neurodevelopmental disorders? These are disorders that occur early in a person's development, and they include intellectual disabilities, autism spectrum disorder, attention deficit hyperactivity disorder, specific learning disorders, motor disorders, and tic disorders. So in order to qualify for an intellectual disability, an individual must have deficits in intellectual and adaptive functioning. So they have a lower tested IQ, but also they're struggling to function in society, so academically or with daily life. So 3 criteria must be met. The person must have deficits in reasoning, problem solving, planning, learning, or judgment. And the deficits must result in failure to meet standards for personal independence and social responsibility. And this must occur during the developmental period, so as a child. Rosa's Law is a federal statute in the United States that replaced the term mental retardation with intellectual disability. So intellectual development disorders are another way that these disorders are described. So it was actually listed in the DSM previously as mental retardation, but it's been changed to intellectual disability. So this can occur mild, moderate, severe, or profound. Those are the levels of severity. And they're defined on the basis of adaptive functioning, not IQ, because adaptive functioning determines the level of support needed. And when you think about it, when you're treating someone, IQ number doesn't really matter. It's really about the accommodations that they need or the types of, tutoring or help with daily functioning that they might require. Global developmental delay. So this is diagnosed in children under age of 5 when the clinical severity cannot be readily assessed. Obviously if there's an intellectual disability and they're very young, it's going to be difficult to test. And it can be diagnosed when an individual fails to meet regular developmental milestones in several areas of intellectual functioning. And you can use this term in children who are too young to participate in standardized testing. So you would want to hold off on that. You might give that as a preliminary diagnosis, but then you would want to go back and test when they're old enough. Unspecified intellectual learning disability is a term used in children who are over age 5 when assessment of the degree of intellectual disability is difficult or impossible. So this could be due to a lack of locally available procedures or testing materials, or due to physical impairments such as blindness or deafness. There could also be severe behavioral problems or another mental disorder present. This category should only be used in exceptional circumstances and does require reassessment after a period of time. So we're moving on now from intellectual disabilities to communication disorders. So things that fall under the communication disorder category include language disorder, speech sound disorder, childhood onset fluency disorder or stuttering, and social pragmatic communication disorder. Language disorder is a persistent difficulties in the acquisition and use of language across modalities due to deficits in comprehension or production. So they're either unable to make the sounds or understand the sounds. Language abilities are substantially and quantifiably below those expected for age, resulting in functional limitations. And the onset of symptoms is in the early developmental period, and difficulties are not attributable to other medical or neurological conditions, and it's not better explained by intellectual disability or global developmental delay. So these kids might be the ones that would qualify for speech services at a young age in elementary schools. Speech sound disorder is a persistent difficulty with speech sound production. Disturbance causes limitations in effective communication that's interfering with their language skills. And onset is an early developmental period, and it's not attributable to congenital or acquired conditions. So other medical conditions have been ruled out. Okay, childhood onset fluency disorder or stuttering. So this is related to disturbances in normal fluency and time patterning of speech that's appropriate for age and language skills, persists over time, and has one or more speech disturbances. Disturbance causes anxiety about speaking and or impacts functioning, and the onset of symptoms in the early developmental period, and it's not attributable to neurologic insult. Social pragmatic communication disorder involves persistent difficulties in the social use of verbal and nonverbal communication. So there are deficits in using communication for social purposes. Difficulty in changing communication to match the context of the situation, difficulties in following the rules of conversation, difficulties understanding what is not explicitly stated, and these deficits need to result in functional limitations to communication. The onset of symptoms need to be in the early developmental period, and the symptoms cannot be due to another medical condition, neurological condition, or mental disorder. And now we're moving on to autism spectrum disorder, which is another common disorder you will likely see in schools working with young children. These individuals have persistent deficits in communication and social interaction. They have restricted or repetitive patterns of behavior, interests, or activities. The symptoms must be present in the early developmental period, and the symptoms have to cause impairment in social occupation or other important areas of functioning. They have persistent deficits in social communication and social interaction. They have an abnormal social approach or failure of normal back and forth conversation. They have problems with nonverbal communication like eye contact or gestures, and with developing, maintaining, and understanding relationships. A lot of individuals with Asperger's syndrome disorder have a hard time reading the social cues of others and being able to see and understand emotions on the faces of other people. So that impairs their social ability to connect. They also often have restricted or repetitive patterns of behavior, interests, or activities. So that can be repetitive motor movements or speech, insistence on sameness. So routines and patterns are really important to kids with ASD and adults with ASD. They have highly restricted interests and increased or decreased activity with sensory input. So highly restricted interest, meaning like maybe they're obsessed. I don't know if you've, what is that show? There's a show on Netflix about ASD, and it's called Abnormal. And the kid is really obsessed with penguins. And so his highly restricted interest includes penguins. So he loves anything that has to do with penguins, and he knows everything that has to do with penguins. But he's not that interested in other, maybe, I don't know, seemingly normal activities developmentally as other students in his age range. And he may have increased or decreased activity with sensory input. So I noticed for the kid in Abnormal, he like when he gets overloaded, it's just too much. Like if there are too many sounds, too many people, too many senses, too much light, then he can get overwhelmed. And that's very common for kids with ASD. And then some kids need like a sensory box. So something you can do as a counselor is provide a sensory box for ASD kids with like dry noodles, rubbery things, anything with a texture, like Play-Doh can be really soft texture, or maybe like a bumpy texture. Those can be good to help kids focus in class so they're not overwhelmed by the sensory things in the room. Yeah. Symptoms must be present in the early developmental period. They may not become fully evident until social demands limit capacities. They may also be masked by learning strategies in later life. And you can diagnose both an intellectual disability and autism spectrum disorder in the same person, but symptoms for both must be present. So previously in the former DSM, there was Asperger's disorder. And Asperger's includes higher level functioning, but still with some of these repetitive motor movements, restricted interest. So like a lot of the symptoms of autism, but without the intellectual disability. And previously, in autism spectrum disorder, the level, like if the level of functioning was more severe, they would give an autism diagnosis. Now it's really seen as on a continuum. So someone can be high functioning and very academically inclined, but struggle with the social aspects of autism spectrum disorder and maybe the sensory pieces, even like the strict adherence to schedules and routine. And again, going back to that show Abnormal, if you haven't seen it, it's a really good show. You should check it out. Going back to that show, he seems like a super high functioning, someone who maybe would have been considered Asperger's previously, because his academic levels are high and he has a lot of artistic and creative talents. Okay, so yeah, as mentioned before, now Asperger's disorder is lumped into autism spectrum disorder, and it's considered on a continuum. Or you could give pervasive developmental disorder NOS, or not otherwise specified. That was a previous diagnosis in the DSM-4, but now you just give autism spectrum disorder. So moving right along to other neurodevelopmental disorders that you will likely see in childhood. Attention deficit hyperactivity disorder. Again, this is one that you will more than likely absolutely see if you're a school counselor or you're working in an outpatient facility with children. So attention deficit hyperactivity disorder is a persistent pattern of inattention and or hyperactivity and impulsivity that interferes with functioning or development. For children, 6 or more of the symptoms have persisted for at least 6 months to a degree that it's inconsistent with developmental level and that negatively impacts directly on social and academic occupational activities. For older adolescents and adults, ages 17 and older, 5 or more symptoms are required. So one less symptoms required. Several inattentive or hyperactive impulsive symptoms are present prior to age 12. And several inattentive or hyperactive impulsive symptoms present in 2 or more settings. So at home, school, or work with friends or relatives, or in other activities. Clear evidence that these symptoms interfere with or reduce the quality of social, academic, or occupational functioning. So a note about this, attention deficit hyperactivity disorder is one of the most overdiagnosed disorders in the DSM. So we want to be really careful not to overdiagnose kids. Sometimes normal hyperactivity and the active nature of children can be considered ADHD when really they're just normally developing. Also, if activities are being presented like in classroom settings or at home that are not of the appropriate developmental level and may look like the kids are inattentive or hyperactive, but really they're just not really comprehending or responding in a way that would be appropriate because they're given inappropriate materials developmentally. So that's something that we want to be aware of as well when we're diagnosing this. All right, let's look at the chart. So these are symptoms because there's an ADD, which is like just the inattentive type, and then there's the hyperactivity and impulsivity piece. So in ADHD, you can see both, and in the ADD non-hyperactive type, you may just see the symptoms of inattention. So I'm just going to give this a second so you can read it. But on the inattention side, failing to give close attention to detail, making mistakes, difficulty sustaining attention in tasks or activities, not seeming to listen when spoken to directly, not following through on instructions and failing to finish schoolwork or workplace duties, difficulty organizing tasks, avoids or dislikes tasks that require sustained mental effort, loses things necessary for tasks or activities, is easily distracted and is often forgetful. And then the symptoms of hyperactivity and impulsivity include fidgeting, tapping, squirming, leaving seat in a situation when remained seated as expected, often runs and climbs when it's inappropriate. And in adolescents or adults, that is just a feeling of restlessness. Often unable to play or engage in leisure activities quietly, is often on the go as if driven by a motor, talking excessively, blurting out answers before a question has been completed, difficulty waiting their turn, and interrupting or intruding on others. So remember, you need 6 of these to diagnose a child and 5 for an adult. I feel like we can all relate to a lot of these. All right. Other specified and unspecified ADHD, you're going to see this a lot, the other and unspecified. So it basically what this means in the DSM is that we have a category that we can diagnose someone with when they're meeting a lot of the criteria and we think it might be whatever disorder it is, but maybe they don't meet all the criteria, or they almost meet all the criteria, but they don't. And so what I put here is it looks right and feels right, but doesn't meet all the criteria. So you want to check the DSM before giving someone an other specified or unspecified diagnosis of any kind. All right, let's talk about learning disorders. So we're moving on from ADHD. We've talked about ASD. We've talked about intellectual disability. Now we're going to talk about specified learning disorders. So obviously something you may see on an IEP, definitely on, maybe talked about in an ARD, because these are your learning disabled folks. So to be diagnosed with a specific learning disorder, a person must have difficulties in at least one of the following areas. Symptoms must have continued for at least 6 months despite targeted help. So it could be difficulty reading, understanding the meaning of what's read, difficulty spelling, difficulty with written expression, difficulty understanding number concepts, difficulty with mathematical reasoning. So a person with specific learning disorder, his or her affected academic skills are substantially below what is expected for age and causes problems in school, work, or daily living. What's the difference between having a specific learning disorder and just school performance? To be diagnosed with specific learning disorder, other possible causes of learning difficulties need to be ruled out. So the types of specified learning disorders include with impairment in reading, and if the person is dyslexic, you want to specify if the dyslexia affects other issues like math, because sometimes it does. If people are flipping numbers and changing spaces there, it can really impact their ability to calculate effectively. And with impairment in written expression and impairment in mathematics. So these are the specified learning disorders, and you want to indicate mild, moderate, or severe. Moving on to motor disorders. So developmental coordination disorder and stereotypic movement disorder are in this category. Developmental coordination disorder is a motor skills disorder that affects 5 to 6% of school-age children. The ratio of boys to girls varies from 2 to 1 to 5 to 1. So much higher for girls, depending on the group studied. So DCD occurs when a delay in the development of motor skills or difficulty coordinating movements results in a child being unable to perform common everyday tasks. By definition, children with DCD do not have an identifiable medical or neurological condition that explains their coordination problems. So you're going to see kids that are clumsy, that have a hard time tying their shoes, who maybe cannot do some of the basic motor skills that are expected based on their developmental level, like coloring, cutting, building, different things like that. So it's basically an issue with their movement and their ability to learn motor skills. So learning and the criteria are the following. Learning and execution of coordinated motor skills is below expected level for age, given opportunity for skill learning. B, motor skill difficulties significantly interfere with activities of daily living and impact academic school productivity, pre-vocational and vocational activities, and leisure and play. The onset is in the early developmental period, and motor skill difficulties are not explained by intellectual delay, visual impairment, or other neurological conditions that affect movement. Motor milestones are often not delayed. The delay is usually in the acquisition of motor skills. So criterion D require the involvement of a medical practitioner to rule out other explanations for the clumsiness. It says in Canada, only a medical doctor or psychologist is permitted to diagnose DCD. And this isn't something that I've seen LPCs dealing with a whole lot, because it seems like a very specific course of treatment. All right, we have stereotypic movement disorder, repetitive, seemingly driven, and purposeless motor behavior. Hand shaking and waving, body rocking, head banging, self-biting, hitting own body. The repetitive motor behavior interferes with social, academic, or other activities and may result in injury. The onset is in the early developmental period, and the repetitive motor behavior is not attributable to physiological effects of a substance or neurological condition and is not explained by another neurodevelopmental or mental disorder. So you want to specify here if it's with injurious behavior or without injurious behavior. So this might be a kid who kind of can't control their own body, and they have tremors, they're rocking their body, they're banging their head, they're biting themselves, and they're hitting themselves. It's not connected to another issue like ASD or other conditions. Okay, tic disorders. We're moving along to tics. So a tic is a sudden, rapid, recurrent, non-rhythmic motor movement or motorization. Tics can be found in Tourette's disorder, persistent chronic motor or vocal tic disorder, and provisional tic disorder. So the tic can be either a movement or it can be vocal. So they can be simple or complex. Simple motor tics are of short duration, milliseconds, and can include eye blinking, shoulder shrugging, and an extension of the extremities. Some vocal tics include throat clearing, maybe repetitive, sniffling, and grunting, often caused by contraction of the diaphragm or muscles of the oropharynx. Complex motor tics are of longer duration and often include a combination of simple tics, such as simultaneous head turning and shoulder shrugging. So that would be more repeated. And they can appear purposeful, such as a tic-like sexual or obscene gesture. I will not engage in that. Or a tic-like imitation of someone else's movements, echopraxia. So echopraxia can really get kids in trouble because they're obviously they're imitating someone else, which can seem offensive, but really it's a tic. So that can be really troublesome and interfere with their social relationships. Similarly, complex vocal tics include repeating one's own sounds or words, palalia. So maybe they are reading something out loud and then they repeat it. Repeating the last heard word or phrase, echolalia, or uttering socially unacceptable words, including obscenities or ethnic, racial, or religious slurs, coprolalia. Importantly, coprolalia is an abrupt, sharp bark or grunt utterance that lacks the prosody of similar and appropriate speech observed in human interactions. So it could be obscenities, it could be a bark, it could be a noise, it could be all sorts of things. Tourette's disorder. So here's the criteria for Tourette's. Both multiple motor and one or more vocal tics that have been present at some time during the illness, although not necessarily concurrently. The tics may wax and wane in frequency, but have persisted for more than a year since the first tic onset. The onset's before age 18, and the disturbance is not attributable to physiological effects of a substance like cocaine or another medical condition, Huntington's disease or post-viral encephalitis. So you need multiple motor tics. So that's moving your arms, shrugging your shoulders, popping your head, flicking your tongue, whatever it may be that's motor, and one or more vocal tics, as we mentioned before, like echolalia, repeating someone else's words, something like that. Okay. Persistent motor or vocal tic disorder includes single or multiple motor or vocal tics have been present during the illness, but not both motor and vocal. So that's what differentiates persistent motor or vocal tic disorder from Tourette's. So you have just one motor or multiple motor or vocal tics, but you don't have both motor and vocal. So you just have one or the other. You can have more than one, but you just have one or the other. And the tics may wax and wane, but persist for more than a year. The onset is before 18. The disturbance is not attributable to the physiological effects of a substance or another medical condition. And the criteria have never been met for Tourette's. And you want to specify if with motor tics only or vocal tics only. Provisional tic disorder includes single or multiple motor and or vocal tics. The tics have been present for less than a year since the first tic onset, and the onset's before 18. So, provisional tic disorder is if someone's experiencing either motor or vocal tics. Persistent motor or vocal tic disorder is if someone's experiencing vocal or motor tics for more than a year. Tourette's disorder is when someone's experiencing both motor and vocal tics for more than a year. So obviously, if you haven't been working with someone for a whole year, you would give them provisional. You would give them provisional tic disorder. Other and unspecified tic disorder. So again, you're going to want to look at the DSM if some of the criteria has been met, but not all. And that is all I have for you today. There are a lot of neurodevelopmental disorders that impact children. So definitely study that section if you're going to be working with kids. And I hope you have a great day.